Today we'll be talking about multimodal therapy. The text that I chose to do my presentation on is called The Practice of Multimodal Therapy, Systematic, Comprehensive, and Effective Psychotherapy by Arnold A. Lazarus. Arnold Lazarus was a behavioral therapist who became well known for his approach of systematic eclecticism, which differs from other broad spectrum and multimodal platform approaches. And what's interesting about this is Arnold Lazarus actually wrote some of the first texts on cognitive behavioral therapy. And what he found was that just addressing the cognitive and the behavioral aspects of a client's presenting problem was not enough to really promote significant personal, long lasting change. Arnold Lazarus defines technical eclecticism as using many techniques drawn from different sources without also adhering to the theories or disciplines that spawn them. Technical eclectics try to answer the basic pragmatic question, what works for whom and under what particular circumstances? A multimodal therapist, he says, will ask who or what is best for this particular individual. Multimodal therapists are on the lookout for individual exceptions to general rules and principles. This approach allows clinicians to use many strategies and techniques from many theoretical orientations that suit the needs of the individual client. As I stated, multimodal therapy postulates that a clinician does not need to accept the theories or principles of other theoretical orientations, such as those of Freud, Rogers, Ellis, and Pearls, to name a few, in order to use their theories, techniques, and interventions effectively with clients. The multimodal orientation emphasizes therapeutic flexibility and versatility above all else. Lazarus really stresses this throughout the text that we are trying to tailor the therapy and the treatment to the client and not the client to the treatment. The practice of multimodal therapy walks clinicians through the basics of multimodal therapy. In addition to going through the basics, it gives a lot of case examples and exemplars that really drive home the points that he's trying to make in the ways that we use each of the different strategies and aspects of multimodal therapy with clients in sessions. This text outlines how to conduct the initial interview. In addition to outlining how to conduct the interview, it also has quite a few different appendices that lend resources to the initial interview, such as the life history questionnaire, which is similar to a biopsychosocial intake that covers the general information, demographics such as age and ethnicity, a description of the presenting problem, personal and social history, and topics related to each of the basic ID modalities. In addition to this, the life history questionnaire also asks for a sequential history from 0 to 65 and older. And what this asks is it asks the clients to write down within the given age range the things that they can best remember, or the things that most stand out in their memory about each of these age ranges. One can think of this as almost being a very brief early recollection of just a couple of sentences for each of the age ranges. In addition to the life history questionnaire, the book also provides a structural profile inventory. This is a series of statements about oneself, such as I follow good nutritional habits, or I would not be described as a loner, and has the client rate them on a scale of 1 to 7, from strongly disagree to strongly agree. In addition to this, it also provides a glossary of principal techniques. The text also outlines the core tenets of the theory, how to determine the basic ID interactions, the selection of techniques, which is very important for this theory because we don't just haphazardly pull out techniques from various theories. We really want to examine what techniques we think are going to be the most effective with clients and the most suited for the client. Lastly, The text also outlines how to use the therapy in various counseling settings. For example, how do we use this with children, in groups, in marriage therapy, sex therapy, and clients that are presenting with very acute problems as well. So the goals of multimodal therapy are to reduce psychological suffering and promote personal growth as rapidly and as durably as possible. So what he's trying to do is we're trying to really tailor the treatment to the client in ways that the client is going to best perceive the information, really be open to the change, and really create a lot of personal growth that is going to be significant and long lasting. Lazarus really stresses the need to avoid psychiatric labels because when he's found that when these labels are given, very rarely do they have any sort of therapeutic value. In addition to this, he also stresses the importance to recognize that very few problems have a single cause or a single cure. But if we recognize that humans are multi-leveled and multi-layered, we're able to better understand the client as a whole rather than just maybe the superficial areas that the client is showing us. He really stresses this when he talks about the inner circle strategy, where the clients have these circles to them of who they might feel comfortable sharing information with. And the closest zone is zone A, where the client shares with very few people, and it's really just people who, or even a person, who is considered to be totally trustworthy. Circle B is reserved for one's very closest friends, while other good friends may only be permitted to go as close as Circle C, and so on and so forth. So really understanding that clients may not want to divulge these sort of very personal Circle A type problems, but might keep the therapist at a distance of maybe C or D. And how do we work to build that rapport with our clients to get to the more tougher things to talk about? So multimodal therapy looks at human suffering and says that it is dissected and understood through the discrete but interactive modalities for dimensions of human personality, also known as the basic ID. And when we're looking at the basic ID, we're basically talking about the whole person, understanding that there's not one specific factor that contributes to the entire presenting problem. There's not just one way to explain the presenting problem. So the B in basic ID stands for behaviors. These are things that we can observe. So this would be something like avoidance, playing sick, playing the sick role, avoidance of mobility or involvement, or bathroom rituals. A is for the affective processes such as fear, panic, anxiety, feeling discouraged or depressed. S is for sensations. So these are going to be sensations from obviously the five senses. This can be dizziness, palpitations, tremors, and aches and pains. I is for the images. So these are the images that people kind of conjure up, maybe a poor self-image, feuding with parents, or teasing from a sadistic teacher. C is cognition. So what are the client's thought processes? How do they look at things? Other people see me as odd in particular. No woman would ever want to get close to me. Maybe these are contamination notions or musts and shoulds. I stands for interpersonal. So what are their interpersonal and social relationships look like? Are they timid when they're interacting? Are they almost hermit-like? Or are they very extroverted and really outgoing and very social with others? And D stands for drugs / biology. So do they regularly take any prescribed medication? What do their nutritional habits look like? What do their exercise habits look like? Are they allergic to any medications? Is there any biological history or medical history that we should be concerned with? It is important to note that D does not only stand for drugs, as I said, but can also be medication, hygiene, various things like that, and interventions that could possibly affect personality. So what we're looking to do is we're looking to increase the adaptive functioning and coping within the modalities of the basic ID. And that's where we're really going to promote that growth and decrease the psychological distress. So if you look at the chart that I have here on this slide, you'll see the basic IDs kind of laid out. And what's important about this chart to notice is that each one is basically a two-way street. There's no one basic ID that influences another. Each one has a dual arrow, so an arrow going both ways. And what Lazarus says is that the sequence of events results in emotional disturbance. And so I kind of want to lay out an example of what this means. So let's say you go to the beach, you're out in the ocean, you're having a great time, and you feel like you're touched by something. Something swims past you and brushes against your leg. Then you're sitting there and you're like, oh my gosh, what just touched me? I'm in danger. And you start to be like, what if that was a shark? Or what if I get stung by something? And then your fight or flight reaction kicks in and you run out of the water. And then the next time somebody asks you to go to the beach, you completely make up this excuse to avoid going because you have these images of what happened the last time and you're still really freaked out about it. What Lazarus would say is happening that's causing the emotional disturbance and the avoidance of going to the beach with your friends is that you had a sensation, so something touched you or brushed by you while you were in the water. You cognitively appraised what was going on and you perceived that it was dangerous. You ended up conjuring up images in your head of maybe a shark in the water or maybe getting stung by a jellyfish that led to an overt behavior, the fight or flight response, which then led to an interpersonal interaction of avoiding going to the beach with your friends. So as you can see, the sensation had an interaction with the cognitions, which had an interaction with the imagery, and then the behavior, and then the interpersonal. So he says that basically all of these different ways that the basic ID can interact is what's going to cause the emotional disturbance within the client, thus contributing to the human suffering and the way that we look at how do we change this. So Lazarus in the multimodal therapy really says that in order to understand a person, we need to understand the basic ID. And when we understand the basic ID, we can better fit the treatment to the individual and not the individual to the treatment. And when we can make the treatment fit the individual, we yield more significant changes. There's more collaboration between the therapist and the client. And we work with the client in a way that makes the most sense to them. So by understanding the basic ID, we really are promoting looking at what the client is really experiencing and understanding the client as a whole. Multimodal therapy really encourages collaboration between the therapist and the client. If we are doing an intervention, such as, let's say, journaling, and the client is not completing the journaling and they come to us and they say, I don't see what the point of this is, then we need to collaborate with the client to maybe find another intervention that makes more sense to them, because without the client really participating in their treatment, we're not going to yield significant changes. In addition, going back to wanting to fit the treatment to the client and not the client to the treatment, this is why we work with the client in the way that makes the most sense to them. What is the kind of language that they're using? What do they feel comfortable with doing, what has worked in the past for them, maybe what hasn't worked for the past for them if they've gone to counseling before. So really understanding who this client is. In addition, we would need to treat clients based on their basic ID in different ways. So if we have a client who is going through the affect first, then the behavior, then the sensation, then the cognition, we're going to treat those and maybe use different techniques than somebody who is behavioral, cognition, sensation, affect, again, versus somebody who's cognition, sensation, affect, and behavioral. Each of these different sequences of the basic ID will require different treatments. So some strengths and limitations about multimodal therapy. Multimodal clinicians pursue the basic ID in a precise and systematic way, which really lends itself to being an evidence-based therapy. We're not kind of throwing all of these different techniques and interventions into a hat and just pulling them out randomly and saying, oh, well, I hope that this one is effective for this client. We're really pinpointing who this client is, what their presenting problems are, and where the areas in the basic ID that are really needing to be worked through and changed to enhance that personal growth. Another strength of this is that, like I said, it tailors the treatment to the client and not the client to the treatment. So really, again, promoting that collaborative spirit, really working with the client in a way that makes the most sense to them so that they are invested in their treatment and really do get as much out of it as possible. Another strength that I think that this approach really shows is that it stresses parity and collaboration with the client, as I said. And parity basically means just promoting equality between the therapist and the client. So not assuming this expert role over the client, but really, again, working with the client to understand them, really get where they're coming from, and really figure out what interventions and treatment is going to be the best for the client. If you look on the right hand of this slide, there are two different bar graphs. And another strength to this is that you can use the basic ID to map it out for the client so they can really see. So you can ask the client on a scale of 1 to 10 where they feel they might fall in each of these modalities. So client A at the top rated their behaviors as being a 10. They rated their affect as being a 5, and they rated their sensations as being an 8. And already you can see the difference between each of the modalities. For client B, which is on the bottom, you can see that they rated themselves on the behavior modality as being a 3. Their affect was a 10, and their sensations were about a 9.5. So you can already see that for client A, we would want to maybe look at the affect, the imagery, and the sensations maybe first, whereas client B, we'd really want to address their behaviors, their cognitions, and maybe the drug and biological pieces first. So you can really see how clients can differ and just laying it out on a map. And sometimes Lazarus says that he will have the client create their own basic ID bar chart, and he will create one for the client, and they can use them for comparison. So you can really see the difference between maybe how the client is processing, where they think their primary issues lie versus maybe what the clinician is seeing, and you can really work in that collaborative spirit, like I said. So some limitations to this theory. I actually had a very difficult time finding criticisms and limitations of this approach. So a few that I personally saw with this theory is that it doesn't have as many set principles as other theories such as ones of Freud, um, where a lot of things stem from these childhood experiences and the different stages that Freud puts forth. There's not as many principles and kind of parameters for this theory because it really does draw its techniques and interventions from many other theories. Another limitation that I saw was that it does not show mastery in one orientation or its techniques. Yes, you can be a multimodal therapist and you can master multimodal therapy. However, you're never going to master all the different techniques because, as I've stated, you can draw from really any theoretical orientation as long as it's systematic and precise when deciding upon it for the client's treatment. This approach does not have many techniques of its own. It does have some that I will be talking about, such as the inner circles, as I stated before. And there's a couple of other ones that I'll talk about a little bit later, but it doesn't have a whole slew of techniques specific to multimodal therapy. So those were just a few limitations that I had noticed while going through and reading the text. So this is an evidence-based treatment, and it has been shown to be effective with children, adolescents, and adults across multiple disorders and symptoms. Klontz, Wolfs, and Bivens researched the effectiveness of multimodal therapy and found that it was effective in reducing negative psychological symptoms and enhancing psychological well-being in the participants studied. And that really attests to the main goal of multimodal therapy, as it said, to reduce the negative psychological symptoms and enhance the personal growth within the person to create that long-lasting change. Lazarus claimed that he had a 70% successful follow-up with a sample of complex and difficult cases. So out of the cases that he deemed to be complex and difficulties, when he followed up with these clients, there was still that long-lasting change 70% of the time. So now I'd like to give a case example for the predisposition section of the case conceptualization. So in this example, we have a 40-year-old male presenting with anxiety and panic attacks that have become progressively more troublesome over the past 4 or 5 years. Recently, over the past year or two, he began to limit his range of movement. He stated, "I was on the road a lot and used to travel anywhere for sales meetings, but now I am afraid to be more than an hour from home in case I have an attack." As a result, he was losing business, which in turn often led him to feel depressed. Moreover, during the past year, he had seen specialists for a spat of illnesses, mainly for headaches and stomach pains. He had been in treatment with a psychiatrist the past 3 years, but his condition continued to deteriorate. So on this slide, you can see that I have used a cognitive behavioral predisposition section, and I've integrated it with the basic ID. So on the left-hand side of the slide is going to be the CBT predisposition, and on the right-hand side in the picture is going to be Lazarus's map for the basic ID of the client that I just read. So the client, for his maladaptive cognition, views himself as unable to cope, helpless, losing control, failing in life, and that he will die at 44 like his father did. He views others as being important to please, and that others are critical of his anxieties. He views the world as one similar to his father's world, and that he over-identifies with his father who died at age 44. His maladaptive schemas is that he is defective and doomed to the same script as his father. His maladaptive behaviors include phobic avoidance, loss of control, and staying in bed when highly anxious, and feigning illnesses. So having these sensations maybe contributed, maybe having these feelings of illness that are related to his high anxiety. So if you look at Lazarus's basic ID, you can see that we've touched on the behaviors, we've touched on the somatic symptoms, we've touched on the images, so the views of self, others, in the world. We've touched on some cognitions, that it's very important to please other people. We've touched on some interpersonal, that he over-identifies with his father, and that his wife will mother him for somatic complaints, but that she's also critical of his anxieties. When doing the case conceptualization and using the basic ID, we can really use very many pieces of the basic ID map in other sections. For example, this client, if you look at the D for drugs, takes tranquilizers, smokes about 20 cigarettes a day. So these are important aspects that would go maybe in the health history, or maybe even the previous treatment sections as well. So you can really see that the basic ID really covers most of the case conceptualization when you break it down in this way. And so he also says that when we do this preliminary modality profile, so this basic ID map, each item is discussed with the client in an effort to eliminate any ambiguity, because we really want to be clear and we really want to have a precise understanding of the client, because that contributes to the interventions that we will select. So with that, let's talk about some interventions. So when selecting techniques with this approach, Lazarus recommends starting with the most obvious and logical procedures. If a client is tense, the obvious antidote, he says, is relaxation therapy. If a person is timid and unassertive, assertiveness training, is called for. If faulty cognitions and erroneous belief abound, the correction of misconceptions will be the first avenue of the intervention. And what he also says is that we want to avoid making things needlessly complicated. Like I said, if we see a clear path, if a person is tense, then yes, we want to work with them on some relaxation techniques. We don't want to make things unnecessarily muddy and kind of confusing. We really want to work with keeping things as clear as possible and really facilitating that collaborative communication. So one intervention that Lazarus talks about in the multimodal text is the deserted island fantasy. And what he says is that he was working with a rather difficult client and basically told her that in order to really get to know her, he would need to live with her 24 hours a day, 7 days a week to really get to know her. And she basically retorted with something like, well, if we were on a deserted island, then we would basically be able to figure that out. And so he said to her, well, you know what? If we were, what would it be like? What would this tell me about you? And so what he ended up doing is she ended up going into this monologue about what it would be like to be on this island and what he would learn about her. And from this, he actually got a lot of clinically useful information about her. So once doing this, he started to do it with other clients and found that using this structured, interactive, and projective technique, he was able to obtain a lot of clinically relevant information about clients. So what the Desert Island Fantasy Technique does is it's used to examine the client's capacity for developing and maintaining close relationships. It allows for a certain level of understanding to be established. The clinician is able to get a feel for the client, to be on the same wavelength as them, so to speak. And he states that to know the other person in order to identify with, understand, and help them. So you're really getting to know the client from their perspective through this projective technique. Typically, this technique is used during the initial interview or the second session, but it can be used at any stage. You could almost use this as sort of a progress check with the client and say to them, give them this technique, put them back on that deserted island, and see what maybe has changed from the first time you asked them about the deserted island, to what the deserted island looks like now. So what he basically does is he gives the client a sort of visual of this magic magician coming in and whisking the client off to the deserted island, where they don't have to worry about any sort of survival things, so shelter, food, other provisions like that. Really what they have to decide is, do they want to spend the 6 months on the deserted island in solitude, or would they like a companion of the opposite gender or of the same gender, depending on the sexual orientation of the client, to come along with them for the 6 months, with the caveat that they do not know this person. And he will find, he gets different answers each time, and really the information that the clients share really gives him better insight into each client, and really maybe some personality traits that might not have been so obvious to begin with, just kind of talking with the client. So the other intervention that I chose to talk about is the acting as if technique from Adlerian psychology. So this technique basically just has the clinician ask the client to identify a specific trait that they might wish that they had had, or something that's desired, and ask the client to act as if and to think about how their life would be different and how their problems might be different, if they were to act as if they were more assertive, for example. What would this look like in their lives? So for my intervention demonstration, I will be doing the deserted island fantasy technique. That this is a piece from Lazarus that I will be doing with a role play client, where you can see the change that the client goes through when engaging in this sort of fantasy projection. She goes from basically saying that the companion will not like her because she's negative and nasty most of the time. And he really pressures her to kind of define what some of the time or most of the time is. And by the end of this little piece, she comes to realize that what she originally thought was some of the time actually is not really what it actually is, So there's a little bit of kind of disputation, some challenging in this. So that will be the demonstration that I do. And this last slide is just my references that I've used throughout this presentation.